Hey folks, Scott Weingart here, and this is an EMCrit podcast. And this is in particular an EMCrit trauma podcast, which we haven't done for so long. I don't know why trauma has fallen off from the rotation schedule, but we are back. In fact, I have a lot of trauma episodes planned. So let's get into the topic of today, which is going to be penetrating neck trauma. And we're going to talk about some stuff that is evergreen, that's been out forever. But a lot of what we're going to talk about today is a brand new paradigm shift in the management of penetrating neck trauma. Now, I don't know about you, but when I was raised as a young buck in emergency medicine and critical care, we had all the zones, and you had to memorize the zones, and you had to get annoyed because zone 1 was not at the top, it was at the bottom of the body and worked the reverse order. All that silliness, that's all gone. And that's what we'll talk about today. Before we get in, really quick, we have 2 tickets left for doctors for our Reanimate ECMO conference in San Diego in November of 2024. Just 2. After that, sold out. Maybe the wait list will open up. Maybe it won't. But if you want a ticket, now's the time. There's 2 tickets left and no tickets left for non-docs. Though, again, put your name on the waiting list. All right, let's jump in. Now, what sparked me doing this show was a fantastic review paper from friend to the show, Kenji Inaba, in the Journal of Trauma. And I linked to that in the show notes for this episode at emcrit.org/381. And it's worth a read. Now, what you're going to find discussed in that paper is the basics, but then also this move to the zoneless approach to penetrating neck trauma, which we'll get into shortly. So when a patient comes in with penetrating neck trauma, the first thing you want to ask yourself is, does the patient have hard signs? And they're going to obviate much thinking in terms of diagnostics. We'll talk a little bit about stabilization of patients with hard signs, but let's just go through what the hard signs are really quick. There's the signs of neurovascular injury first. Now, it would be hemodynamic instability attributed to the neck wound, arterial bleeding, an expanding pulsatile hematoma, any pulse or neurologic deficit, and then a bruit or a thrill over the carotid. Bruit means you got to actually listen. I don't have a stethoscope. I have to borrow it from one of my residents in order to do that. So those are the neurovascular signs. And then the aerodigestive signs, the hard signs of aerodigestive injury, are air bubbling out of the wound. That's not good. Extensive subcutaneous emphysema, stridor or vocal changes, or hematemesis. So if they have those hard signs, you're pretty much going to be going to the operating room eventually in most of these patients. Not to say you're not going to be stopping for a diagnostic study. We'll talk about that shortly, but most of those patients are going to be going to the operating room. Let's talk about what to do if they have some of these hard signs. First up, we'll talk about temporary hemostasis. Now, if they are pouring blood out of the wound, your first move, as always, is going to be direct pressure. And that doesn't mean direct pressure with a wad of gauze pads. This doesn't work for any part of the body. What you want is focused pressure. And you want to make the point of focus as small as you can, because that's going to give you the most concentrated force at the area. So what you could try on a neck wound is to try to get proximal and distal control rather than actually just pushing on the wound hole. Now, if that doesn't work, then you can put pressure on the wound hole, but not with a huge wad of gauze. You actually want to get a small kind of bullet of gauze and then, put additional packing above that and make that your direct pressure. You can pack the wound. I think there are better ways in most cases than actually packing that wound. And since you don't have marked gauze pads, it's a pain in the butt. Not for most of these wounds are you going to lose something, but direct pressure is usually a better way to go than packing. Now, a move you should have in your back pocket is, and this is applicable to any penetrating injuries, especially when you have a small wound access site, but a large amount of bleeding, is the Foley catheter. And I first saw this in a gunshot wound to the supraclavicular region. The guy was just pouring out blood, not amenable at all to direct pressure. And we slipped a Foley in, and all of a sudden we had tamponade. We had temporary hemostasis. It was amazing. Classically, this is described with an 18 French Foley. I don't see any reason you couldn't use other sizes if you just couldn't find that, but that's the size that's been most reported on. And I like to actually flush the inner lumen of the Foley with saline so that there's no air in there. I've seen people in the patient whose exsanguinating, they just throw it in there without that. A little leery. You're still going to clamp it, but it just doesn't seem great to put next to a potential rent in the jugular vein, which we know is prone to air embolism, a column of air. So I like to just rapidly flush the inner lumen of that Foley, and then you clamp it. And you clamp it really anywhere on the Foley body, just so that blood can't pour out and air can't come in. And ideally, you're using a non-destructive clamp for that, but do what you can. Do what you can. The clamps that come with the Foleys I found to be kind of garbage. I wish we had ECMO-type non-marring clamps around for all sorts of different stuff. Usually we don't, but you clamp the Foley. And now you're going to place it inside the wound and then gently inflate the Foley balloon with saline or sterile water and whatever comes in the kit. And until you either start getting a little bit of pressure on the pilot balloon or the bleeding stops. And if you need to, you could actually put two in. You could put one facing, towards where you feel the distal portion of the vessel is and one where you feel the proximal portion is, and this will give you distal and proximal control. Sometimes the wound is big enough, like with a stab wound that's /stab, to not have the Foley able to have purchase. It's just going to fall out. The balloon just pops back out. You can put in a purse string stitch or just some stitches to make the wound entrance site closer to the size of the Foley's caliber such that the balloon will stay in. Now, this is written up by Wepner et al. I have the reference for that in the show notes, but we were doing this way beforehand. I think it emerged out of South Africa, where so much good penetrating trauma experience comes from. All right, another option. I don't know if you've seen these. It's the IT clamp, and I don't take money from any companies, as this is pretty cool. The IT clamp will let you take like a big incision, and it's like the things that women use in their ponytails that kind of are like a clamp with little teeth. You clamp your kids' fingers with these and get a big laugh out of that. It's basically that, except instead of these little teeth, they have needles that superficially penetrate the wound edges. And then when you squeeze it, it pulls both wound edges together. It's just like putting in 12 staples in a second. This is also a nice thing, and it's actually approved to use in the neck. So that's another thing to have in your back pocket. All right, airway management. If a patient is showing signs of airway decline and you have to intubate them in the course of penetrating neck trauma, obviously this is a difficult airway. The patient might be bleeding from their airway. They might have a hematoma expanding into their trachea. And depending on the location of the injury, they might have actually had a partial transection of their trachea or their airway structures. First off, if you have an open wound on the front of the neck and you can actually see the airway, then the easiest thing is just intubate through the incision on the front of the neck. And you could do this with a bougie. This way you could actually feel that it's going down past the suprasternal notch, and you can then get hold up. You're like, I'm pretty sure I'm in. Now, we've demonstrated and linked to other places in the blog where if you push hard enough, you get even a aberrant site to go down past the clavicle line. So don't jam it and think this is helping you. But when you gently place it, you should be able to feel that you're in the actual airway, and then you could railroad a tube over it. You could also use a fiber optic through the wound site, but usually if you see it, you just go for it with the bougie. Now, when you're intubating from above in these patients, the ideal, if you have the equipment, is to do an awake intubation. And that could be a topicalized awake, or it could be a ketamine awake. And a triple setup. What does that mean, a triple setup? Triple setup is you have video laryngoscopy, and you have someone to do that because you need 2 airway operators for this technique. And then you have a video bronchoscope and the screen for that. I put one screen on one side, one screen on the other, depending on the spacing. You can't put them both on the same side. In fact, some of the monitors now, the newest GlideScope and newest stores, actually allow you to have split screen and have 2 devices in one airway screen. That's great too. And then you have someone set up for surgical airway. That's the triple setup. Now, the nice thing about this is as you're doing the video laryngoscopy, first of all, you could see what's going on in there. You could actually see if there's any direct pharyngeal wounds, which once the tube's in, it becomes a little bit harder to do that searching to see if there's actually pharyngeal wounds. So that's first off. And then second, it really gives you a clear path. You just follow the blade to get to the airway orifice. And then if there's any kind of holdup of the tube passage, you could just look at the laryngoscope screen and see what the heck's going on there. If you have the capabilities for this, the triple setup is a fantastic thing for these neck injuries. The classic teaching was if you can, intubate them in the OR, but that was predicate on the idea that there would be a lot more equipment in the OR than there is in a trauma bay. And that just isn't the truth anymore. Like in most cases, at my old place, we had far better equipment, far better quality equipment, far better breadth of equipment in the trauma bay than they would have in the OR. We had better fiber optics. We had all of the difficult airway equipment. We had all of the awake intubation supplies, which weren't readily available in the operating rooms. And we had lighting that was just as good. So there's really no reason to take them to the OR for airway management. In fact, the safest place, so that they didn't have to have the transport with an unprotected airway for something like a penetrating neck trauma, was always in the trauma bay. And that doesn't mean you can't get help if you need it, but it's just in terms of geographical location, that was the best way to go. Now, another thing that may screw some of you up is that ideally these patients would be sitting up. And some people who have gotten a modicum of experience with video bronch intubations have learned the way most anesthesiologists have learned, which is from the same place as you would do video laryngoscopy, from the head of the bed with the patient at least partially down. And these patients don't tolerate that very well. They are much better off sitting up. So I would really challenge you, if you do video bronchoscopic intubations, to learn how to do it from both places, from the head of the bed and from the patient's side.